All right, well, I think we're going to go ahead and get started. Thank you, everyone, for attending. We've got some people online, and we've got some people in person here, too. I am excited to talk about gut health. It's a huge topic, but today what I wanted to do at least is give a bit of an overview and a starting point in helping to decipher some common symptoms associated with gut disorders or gut dysfunction. So prepare yourself for a crappy presentation. Yeah, no shame. We're going to go ahead and we're going to talk all kinds of crap stuff. So there we go. Okay, so general overview. What I would like to start with today is just go through what is a normal healthy gut response from the moment we eat till the moment we use the restroom. What is happening, what normally should be happening. I want to talk about what we call gut disruptors. So things that symptoms associated with gut dysfunction, what can cause them as well, and what you can do as well on your own to be able to help to decipher things to some extent, but also to be able to understand a little bit more about what you can do dietarily, lifestyle-wise, to be able to help us in those symptoms. And then I want to put it all together in the context of an action plan. So a few really kind of foundational bullet points on what we can do for general gut health. So when we start about healthy gut function, the first starts with the mouth. So 75% of our starch digestion occurs in our saliva. So it's really important that our food actually stays in our mouth and that we chew it and that we are able to expose all of our foods to the digestive enzymes in the saliva. So the first step of digestion is chewing. So we call that the optimization of mastication. And there's no real set rule to how many times you have to chew your food, even though some would believe that there is. But often what happens is when we do eat in go mode, or we eat on the run, or we eat while we're driving, or we eat when we're not sitting down, we are shoveling it in at a rate faster than we can chew it. And that will impact digestion further down in the digestive tract. Interesting thing, we produce about 1 liter worth of saliva every day. And so as we get talking about things we can do to improve digestion, hydration is a big component because a lot of our digestive juices, from our bile to our enzymes to our saliva, they're all water-based. So the next step along the route is we need to travel from the esophagus down into the stomach. And to do that, we need to pass through a junction. And that junction is guarded by a little valve. And that valve is called the lower esophageal sphincter. So what that does is it basically helps to prevent food from coming upwards. It keeps food staying into the stomach. And interestingly enough, this lower esophageal sphincter is tightly surrounded by the diaphragm. And so again, when we get talking about eating in a rush or eating when we're under stress, what happens then is we're not breathing. The breathing creates a nice micro massage of the abdominal organs. It helps the food as well to move down lower into the digestive system and allows the stomach to empty at a healthy rate. Then we get into the stomach. And when we start to see food, think of food, or smell food, we start to secrete digestive juices in the stomach. The primary one of that is hydrochloric acid or stomach acid. And as far as stomach juices go, again, lots of fluid secreted. So about 2 to 2.5 liters a day of stomach acid produced, stomach juices produced. The stretch receptors in the stomach notice that the food is coming, and so they will start to respond as well too as the stomach stretches. The thing we want to keep in mind when we're eating in the rest and digest nervous system state, that promotes digestion. When we're eating again in go mode or fight or flight, that tends to halt digestion. So things don't move as quickly through the digestive system and things start to come to a halt. And that's when you kind of feel like food is sitting in the pit of your system, or you feel indigestion after you eat. So the purpose of the stomach acid, very important. Often we think about suppressing stomach acid, but it serves a very important function in the body. So the pH of the stomach is about 1 to 2. So it's a very acidic environment. The stomach acid kills bacteria, it kills parasites, it kills anything that maybe we haven't unintentionally ingested through our food and drinks. So it helps to keep that environment relatively sterile. Stomach acid is also required to cleave proteins from our food. So we need to break down proteins into single amino acids, and stomach acid helps us to do that as well. Stomach acid unbinds vitamin B12 from foods, and then we can use that free form of B12 to finally absorb. So again, stomach acid important for B12 absorption. And it also ionizes other minerals for absorption. So calcium and zinc and iron cannot be adequately absorbed if we don't have the stomach acid to be able to ionize it. So normally the stomach, the transit time through the stomach is about 1 to 5 hours. So that's a big range. Some of that can be within the realm of normal. You can have a slower emptying stomach, or you can have a faster emptying stomach. And a lot of that will depend too on the meal that you just ate. So if the small intestine is irritated or if it's gassy, there can be a lot of upward distension in the abdominal cavity. And that can cause the stomach then to empty a little bit slower. If you're having protein and fats with your meal, that will cause the stomach to empty a little bit slower as well. And so that's why a quote balanced meal with proteins and fats always seems to be a little more filling than a meal that doesn't have proteins and fats in it. So then we get into the small intestine. And so the small intestine is 7 meters long and a diameter of about 1 to 1.5 inches. So it's a long, narrow tube. The bulk of the small intestine is where we absorb a lot of our nutrients. The water is absorbed in the colon, the nutrients absorbed in the small intestine. And when we start to talk as well too about digestive juices that come into the small intestine, there's lots of those that start to enter. So once we get into the small intestine, the pancreas and the liver starts to release bile into the small intestine, and the pancreas releases its digestive juices, and those are enzymes that help to digest starches and fats and proteins as well too. Now, interesting thing with the gallbladder. So our liver makes the bile, the gallbladder stores the bile. The gallbladder's job is to pulse bile in small little pulses in response to fats with a meal. And that bile emulsifies those fats and allows us to absorb those fats, but also the fat-soluble vitamins as well. So if we are not consuming fat, and that often happens on, say, an ultra-low fat diet, again, or maybe not a balanced diet, what happens then is the bile doesn't get released, and the bile can become sludgy, quote sludgy, which is really kind of a very apt description. It just doesn't flow as well. And the interesting thing with bile is that it has a laxative effect. Bile acts almost like a burr in the intestinal tract, like a bottle brush in a way. And so when we have a meal with fat, we're releasing the bile goes in there and emulsifies everything, but at the same time, it encourages the movement of all of that food further down into the intestinal tract and encourages regularity. If we're not getting bile secretion because it's sludgy, then what happens is things again can halt and can slow quite a bit and create sometimes some constipation. The opposite can happen in people that have had gallbladder surgery and a gallbladder out. Is some people will notice that after gallbladder surgery, their digestion is just never the same. If they eat too much fat at once, they get diarrhea. And that is because instead of the gallbladder is not there to pulse the bile in small little increments. So instead you get bile flooding, the bile exits the liver immediately in response to a high fat meal. And that bile being a laxative, boom, everything moves quickly, okay? So again, the pancreas releases enzymes. We think of the pancreas as releasing insulin, it does that, but it's a different part of the pancreas that releases the digestive enzymes into the small intestine. So the lining of the small intestine looks like shag carpet. It has projection called villi, and the job then of that is to increase the surface area. So there's a lot of absorptive area in the small intestine to absorb a lot of those nutrients. And we mean vitamins and minerals and single sugars and single fatty acids and single amino acids broken down from foods. But what the brush border also does, what this lining of villi, the shea carpet also does, is it further secretes more enzymes into this mash that is called digestive chyme. And what that happens then is those particular enzymes from the brush border of the small intestine, they break down certain types of sugars called disaccharides. And that's where we get some of our lactase enzymes from, and maltase enzymes. So these particular two sugar molecules, like lactose, sucrose, and maltose, those require digestive enzymes from the brush border of the intestinal tract for their breakdown and their absorption. And so as we get talking further, we're going to talk about how when this villi border is compromised, that also will affect our digestion of certain types of foods containing these sugars, because we're not making and producing those enzymes that we need to be. So when the lining of the gut is healthy, the carbohydrate digestive enzymes are produced normally. And so this is just a little bit of an illustration of what a healthy gut cell can do is produce these enzymes. An unhealthy gut cell cannot produce these enzymes, and so that will compromise digestion. So absorption in the small intestine, on the outside layer of the small intestine is very, very vascular. We have a network of a lot of blood vessels that will bring whatever has been in the gut finally into circulation. When we eat something, it does not formally enter our circulation, doesn't enter our body, unless the gut lining decides it's going to enter the body. And a good, strong gut lining will only let pass through those things that the body recognizes as single molecule entities: vitamins, minerals, single amino acids, single sugars, and single fatty acids.
Single sugar, sorry.
Yep, so glucose is an example, and fructose is an example of a single sugar. Yeah. Okay, then we get into the large intestine, small intestine to large intestine, 10 feet long, 3 meters long. That's a lot of the intestinal system. Okay, main function for the colon, which is the large intestine, is to absorb water. That's its main function. It also hosts a lot of the gut flora. The bulk of the gut flora in the body is actually held within the colon itself. So generally the colon contents move at about 5 to 10 centimeters an hour. So very gentle peristaltic movements will move all of those digestive products through the 10 feet of colon. About 500 to 1,000 species of bacteria are thought to live in the gut. To be honest, we really don't know. There's probably more of those that we haven't even identified. It's such a universe unto its own, our gut microbiome. 60% of a bowel movement is bacteria. So that's important, because if we don't have a lot of gut flora because we've been on antibiotics, or we don't have a very fiber-rich diet on which these flora thrive, that unto itself can cause constipation. And I find clinically that probiotics are probably even more important for some people than fiber in being able to regulate their bowel movements, because the bulk of what they are excreting and the volume in the colon is related to that bacterial balance. So a slow bowel transit time. So that means, things not moving through very well or very quickly. Associated with diverticulitis, again, an imbalance in the gut flora, and also some reports to colon cancer as well. So it's important to keep things moving, but not moving too fast. So there's that happy medium, that Goldilocks regularity. So how do you know your transit time? Well, you eat beets, as we know, it will eventually pass through, and you can see that reddish color with the stool. The other is to do something called the Blue Poop Challenge. And that is actually online. It's a recipe for muffins that you make at home that contain blue food dye. And you eat a couple of these muffins and you wait to see how long it takes before things turn blue. And you can look it up. It's all over the place. And so generally, what we're looking at is a normal transit time of around 35 to up to 60 hours. So for you to eat a meal and then in an hour have a bowel movement, that may not be from what you just ate that meal. If it is, then that's too fast of a transit time. Okay, so there's something else going on.
35 hours to 50.
No, sorry, 25 hours to 60. Okay. Yeah. And it really depends too on geography as well, you know,
So let me just ask, when you're saying 25 to 60, you do this blue test, do you think it's important for everybody to do that so that they know how long their time is, whether they need to adjust their diet or start taking supplements or?
yeah, well, you know, it's kind of fun. I mean, if you want to, I mean, you can do it for fun, right? Just if you're looking for that curiosity. But I tend to recommend this for kids in particular, because sometimes they don't really report, really, you know, and so that, or again, if there's concerns with, you know, I feel like I'm regular, but at the same time, you know, it's incomplete or it's difficult. That's another indication for you to do that.
Okay, so if it's less than 25, you should change something. And if it's more than 60, you should change something.
Yeah, in that vicinity. Yeah.
Okay.
Yeah. 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 So let's talk a little bit about gut microbiome. So they're considered to be the forgotten organ because they're believed to have such a profound effect on overall health as well. And so about 3 to 5 pounds of gut flora exist in our intestinal tract in a healthy gut. And so what do they do? So one of the primary functions of the gut flora in the colon is that they ferment fibers into something called short chain fatty acids. And these short chain fatty acids are a primary food source for the cells of the gut lining. So the bacteria in the gut promote a nice, strong, patent membrane gut lining so that we don't develop what's called a leaky gut. And a leaky gut is when things pass into circulation that shouldn't. The gut isn't as selective as it should be. So instead of these single sugars and single amino acids and single fatty acids being absorbed, we get undigested particles passing through into circulation. And that's when we start to see immune activation across the board, whether that be inflammation or whether that be some tendencies towards autoimmunity as well, heightens the immune response. Short chain fatty acids are also thought to have an impact on blood sugar levels, but also too on appetite control. And so short chain fatty acids are thought to have a bit of an appetite suppressing effect. So when we have good levels of good gut flora, we have good levels of fiber, which the flora feed off of. So where we have good levels of short chain fatty acids in the gut, we seem to eat less. Okay. So the other function of the colon bacteria is they seem to train the immune system to some extent, to be able to coexist with friendly flora and to be able to develop tolerance to some environmental exposures as well. There is something called the hygiene hypothesis, which hypothesizes that when we are existing in an environment that is over clean or over hygienic, what happens is our immune system doesn't become as smart and it can't differentiate as well between what is a threat and what isn't. And they did some studies actually in Scandinavia, I believe it is in Sweden, and they found that families that had a dishwasher had more rates of allergy and eczema in the children than families that hand wash their dishes. And all the other factors were controlled for, and they had concluded from that exposure to super clean is not necessarily a great thing overall for our immune system. And so having this population of 5 pounds of these organisms living within us seems to be able to help to keep our immune system dampened down so it doesn't overreact, but also stimulate it enough so that it's able to mount a challenge when it needs to. The good flora also keep all the bad flora in check. So we know of yeast, candida issues. We know, again, parasitic, traveler sicknesses. Good gut flora helps to outcompete. It's like a war zone in there in a way. And so they tend to outcompete that way. Good gut flora also brings biotin and vitamin K. All right, so what's normal for bowel movements? So color, all shades of brown are considered normal. There can be some changes in color with bowel movements. So green Pumpkin seeds can cause that. Kale can cause that. Some probiotics can turn the bowels a bit green as well. Okay. Clay-colored or white-colored stool sometimes gives an indication of bowel, a lack of bowel, or perhaps even a bit of an obstruction at the level of the gallbladder. And so clay-colored stool or light-colored stool is something that generally we need to investigate to some extent. Red, obvious red. If there's obvious red with a bowel movement, then we have to rule out bleeding at the end of the GI tract. Sometimes hemorrhoids are further down in the intestinal tract. Rectal bleeding, fissures, again, beets sometimes can create that redness. A black tint to the stool. Iron supplements are famous for causing darkening of the stool. But also we have to be careful to of blood loss further up in the GI tract, which is called occult blood. So if there's bleeding from higher up in, say, the stomach, from an ulcer, or from an inflamed area or ulceration in the GI tract, it may not appear as blood in the stool because it has already traveled through the colon. And so if there is occult blood, which is blood that we can't see, but it's there, it's usually picked up on that fecal occult blood test, which you may have had done, which is your stool test that you take that looks for blood. And that is generally a first screen to be able to see if there's anything that needs to be investigated for that. Oh, and black licorice can cause black stool too. So, just so you don't worry needlessly if you're like a black licorice. Frequency. So average of 3 times per day to 3 times per week. Really, they did a multi-population study from countries all over the world, which I think we really have to do because diets vary so much and innate changes in genetic differences as well too in transit time. So 3 times a day to 3 times per week. So that's a huge variation on quote normal, okay? So what's healthy in terms of form or shape? So just regular time to talk more about this, all this crap, right? So the Bristol stool chart. So this is a famous diagram. It just goes through different forms of bowel movements, which are considered to be healthier than others. Certainly, we don't want liquid stool. That tells us that things are moving through too quickly in the digestive system. Something is causing irritation, so therefore you're not going to be absorbing calories, nutrients, anything. But at the same time, we don't want rabbit pellets either. And we don't want difficult passage of the bowel movement. So what's considered to be, quote, healthy is the type 4, type 5. So again, sausage-like, the sausage-like passes easily, maybe 1 piece, or it may be multiple pieces, but again, well delineated, I guess, margins, you could say, with the bowel movements. Clear-cut edges, they say. Soft blobs with clear-cut edges. Okay. Sausage, but with cracks on the surface. So noticeable little rabbit pellets, but making up one sausage, that's not ideal either. So again, there's this Goldilocks thing that we're looking for. Okay, gut is the second brain. This is another really burgeoning area of research as well, and how our gut affects our mental health too. We realize that about 90% of the serotonin in the body is actually created in the gut. And the wall of the gut has up to 7 different types of receptors for serotonin. And when we start to look at some of the prescription medications that are used for IBS in particular, there are several of them that actually work on serotonin. We also know that some of the medications, the SSRIs, Zoloft, Prozac, sometimes do have digestive symptoms as side effects. And again, that interplay between the gut and serotonin. There are more nerves in the gut than in the spinal cord. And most of these nerves, though, communicate from the gut to the brain, not as many from the brain to the gut. And so that really tells us that what's going on in our gut can certainly talk to what's going on up here. So let's talk first of all about gut disruptor 1. So we're going to talk a little bit about food intolerances because there's 3 different types of reactions to foods, and they're all food allergy, food intolerance, and food sensitivity. And those terms are often used interchangeably, but they're very different in how they're tested and the symptoms that they cause. What we want to focus on right now are what are called food intolerances. And those are foods that the gut doesn't like. contrasting to food allergies, which are foods the immune system doesn't like. And so they are very different reactions and they manifest in different ways. So food intolerances generally come about because we don't have adequate enzymes to digest the foods that we're eating. And we do see that some of these travel through lineage. So we do see some commonalities among family members. One of the most common ones we think of is lactose intolerance. So the inability to digest the lactose, which is the sugar in milk and in dairy foods. We do see commonalities that does tend to travel in families. But at the same time, we can also have an induced lactose intolerance from a GI infection, which we'll talk about later on. If you're not completely digesting the foods that you're eating, the flora in the gut will. And if you're experiencing a lot of gas or distension, that's often a byproduct of fermentation in the gut. So when we start to look at food intolerances and how do we figure this out, sometimes they can be frustrating to figure out. You realize that when you eat sometimes or eat certain things that you start to feel gassy or you feel uncomfortable or distended, but you can't quite figure out because it's never the same. That's often the thing with food intolerances is they have a threshold level. So a little bit may be okay, but then if you start to eat that problem food every day, you're okay for 3 days. By the 4th day, you may have reached that threshold level and then you have a bad gut day. And it's not necessarily what you ate on that 4th day, but it was a cumulative effect of eating those problem foods over 3 or 4 days in a row, where your system says, I just can't do it. I just don't have the digestive makeup to be able to digest that food that frequently. And so it becomes a little difficult then to trial and error it, you know, because you're wondering, well, I had dairy today and it was okay, but yesterday it caused a problem. And again, it may be sometimes what you're eating the food with, but it can also be whether you've reached that threshold on tolerance or not. Different than allergies. Allergies, every time you eat a food, you react. It's very reliable. So they're easier to figure out, unfortunately, the hard way. Intolerances are a little trickier. And we had also talked too about the condition of the gut. The healthier your gut function, the better your gut microbiome, generally the higher your threshold, even on inherited food intolerances. Okay. So problem foods also cause subtle gut irritation that can affect the bowel frequency. They can affect inflammation, and then they can also affect absorption. We can have induced food intolerances after a gut infection. So if you had a bad case of, say, traveler's diarrhea, or if you had a lot of digestive upset with a COVID infection, or there was for some reason or another a round of antibiotics and you experience a lot of diarrhea and things just, digestion just has not been the same since. A lot of irritation, inflammation, even for a period of time, can disrupt that brush border enough so it's not producing those enzymes that digest some of those sugars. And so even though your diarrhea may be better, your brush border hasn't yet regained that capacity to produce those enzymes again. And one of the most common situations we see here is someone with a gut infection that has caused a lot of diarrhea that just can't digest dairy in the same way that they used to because of the effect of the no, usually often we can rehab things to the point where they can tolerate it again. Because again, we just have to get that gut flora back to where it needs to be. We need the milk digesting flora in there. All of your lactobacillus bacteria, lactobacillus meaning milk digesting. So those help us tolerate dairy foods, even if we have a certain amount of intolerance to it. Okay, so we hear about gluten intolerance and celiac. So gluten intolerance is talked about a lot these days. The difference between celiac and gluten intolerance, celiac is an allergy to gluten. And there is no amount of gluten for someone with celiac that is okay. And so as opposed to gluten intolerance, where people with gluten intolerance may notice that if they have obvious gluten, that they maybe don't feel well, maybe they feel bloated, or they figured out that for some reason or other they get brain fog, or they feel tired, or whatever it is after. But a little bit may fall under the radar. So they may be okay, they don't necessarily have to be as strict as someone with celiac. So again, it's a matter of threshold. They will generally test negative on celiac tests. So if you get the blood test done, the antibody levels for celiac, They'll be a negative celiac, so they think, well, I don't have a problem with gluten. Well, they may have a problem with gluten, but it's not necessarily a gluten allergy. It may be an inability to produce the enzymes required to digest the gluten. And so then they'll figure out, I just feel better without eating a lot of gluten, so I'm going to adapt and I'm going to find other alternatives. And so they just limit it, but they don't necessarily have to strictly avoid it. Dairy intolerance, again, versus lactose intolerance. So lactose intolerance is the inability to digest the milk sugars. Dairy intolerance can include lactose intolerance, but also includes the inability to digest milk protein or casein. And I often find that those two situations actually overlap quite a bit. Occasionally we find purely lactose intolerance. More often we find the casein intolerance as well. So in that case, someone's using lactose-free milk or lactose-free cheese, and their symptoms are a bit better, but they're not quite there yet. But then you take them off of the casein, the milk protein as well, seem to feel better. Testing methods for intolerance. The gold standard in determining food reactions, at least intolerance reactions or gut reactions, is to do the old-fashioned way, and that's the elimination challenge. So you take out of the diet for a certain period of time the most common problem foods that trigger some of your symptoms. Even 2 weeks is often adequate to be able to know whether you're trending in a better direction. And then you gradually, systematically reintroduce some foods back in so that you can see which are triggering reactions or what amount you can tolerate without tipping the balance and surpassing that threshold.
So if we want to jumpstart that at healthspan, can we have blood work done to test our food intolerances?
Yeah, well, there are blood tests that can be done. They generally look at a panel of 100 different foods, and they're usually like whole foods, so fruits, vegetables, meats, dairy foods. They're not chemicals like aspartame or red food dye. So we're not looking at that, but we're looking at foods. And it'll rate low, moderate, or highly reactive foods. And it's a good starting point, but no food testing is perfect. It misses stuff. And the reason for that is because they're reacting your blood. It's a blood test. You get it drawn at Life Labs. They react your blood with the food antigen in a petri dish, and they see what happens. And that doesn't mimic the natural gut environment. You're introducing the food into, again, this very dynamic situation with all these gut flora that have their own impact on the foods you're eating. So it gives a bit of maybe what I call a sterile idea of what might be irritating or aggravating, but I often find a combination of the two works the best. So that is what, get your test drawn. You have 2 or 3 weeks before the test results are available. In the meantime, start an elimination and challenge routine. And then using your test results, then we gradually reintroduce foods in based on what your test results show. But then we have to realize that your body response trumps what's on paper. Right. So if you're introducing a food that looks okay on paper, but you're introducing it in your system, it's like, no, it just doesn't work. We have to trust your body. Yeah. So yeah, we do that all the time with people and determining those reactions, whether it's IBS or just general health or inflammation or autoimmune, to see the effects of foods that way. So constipation. So constipation is a biggie as well. About 15 to 30% of people in North America experience constipation, at least in part. It's defined as difficult, unsatisfactory, and or infrequent bowel movements. So again, the foundation of constipation diagnosis is that there is usually some amount of discomfort or straining associated. If you are having a bowel movement once every 3 days, but when you go, it's easy, it's complete, it's no issue, it's formed, it's not rabbit pellets, then that is not necessarily a firm medical diagnosis of constipation. So common causes, lack of fiber is a biggie. I find that sometimes we say, okay, yeah, fiber, and then we gloss over it. But I'm going to show an example about how even the healthiest of diets sometimes doesn't have enough fiber in it. And again, we talked about fiber as being the food for the healthy flora. We can't build a healthy or grow a healthy gut flora without the right fiber in there. But it also, again, helps with satiety, it helps with blood sugar control as well. So as adults, we require about 30 grams of fiber per day. Lack of fluid, again, we talked about all those digestive juices all the bile made with water as well. So lack of hydration can lead to slower digestion and slower transit time. And then medication side effects. So codeine in particular, sometimes antacids, diuretics, sometimes antihistamines can slow things at least temporarily. Supplement side effects. So fiber supplements can be a bit of a catch-22. So if you're taking a lot of fiber all of a sudden, immediately, but not necessarily hydrating, that can bind things up also. And so the hydration is an important piece with any particular kind of supplemental fiber, like a Metamucil, if you're starting with that. But with fiber, it's always best to gradually increase your fiber level rather than to go low fiber to high fiber overnight, even with the best of intentions, because your gut flora also has to adapt to all that extra flora. And what a lot of people will find is if they go to high fiber all of a sudden, or if they have a day that's particularly high fiber, that they do feel gassy and bloated. It's just because the gut flora hasn't adapted to that level of fiber. You don't have enough of the flora to work on the amount of fiber you bring in. Iron obviously can have constipating side effects as well. Sedentary lifestyle, we work with gravity. So again, moving around, jumping, staying active helps with moving things. And again, the lack of beneficial flora in the gut, particularly after antibiotics. Hypothyroid can manifest. One of the primary symptoms of hypothyroid is constipation. And again, we talked about that sluggish bile. So particularly someone who is on an ultra low fat diet, and the bile is just not releasing like it should, then that can also, we're not getting that natural laxative effect of the bile. Food intolerances can sometimes contribute to slowing the bowel down as well too. Okay, so fiber counter. So 2 scenarios for breakfast. Scenario 1, we're doing half a cup of cooked oatmeal, which is 3 grams of fiber. We're doing 2 tablespoons of ground flax seeds or hemp seeds, which is about 8 grams of fiber. We're doing a small pear with skin, which is about 3 grams of fiber. For lunch, we're doing a bean salad, half a cup of cooked beans, half a cup of green beans. We're doing half a cup of lentil soup for dinner. We're doing half a cup of broccoli, half a cup of brown rice. That's 35 grams of fiber. 35 grams of fiber. Okay. Now, scenario 2. So 1 slice of multigrain toast for breakfast with some peanut butter with a banana. We've got a couple of eggs with iceberg lettuce, a cup of cucumber with an apple. We've got half a cup of white spaghetti pasta. We've got a 1/3 of a cup of tomato sauce with meat, and we've got 2 cups of Caesar salad. That's 13 grams of fiber. So when we talk about fiber, there's 2 forms of fiber. There's soluble and there's insoluble fiber. And the insoluble fiber is the gritty stuff, you know, like flax seeds. When you mix flax seeds in water, there's that grittiness. Flax seeds have a lot of insoluble and a little bit of soluble, as opposed to your chia seeds. They have more soluble and insoluble, so they absorb a lot of water. Both soluble and insoluble have important but different functions. So the insoluble, the gritty stuff, is what goes in and creates heaviness in the gut, and it creates bulk in the gut. The insoluble absorbs a lot of water. It's like the sponge, so it maintains it maintains form of the bowel movement, so things don't get too runny, but at the same time, it prevents it from stool from getting too hard. And the soluble fiber is the type of fiber that those gut flora like. So the gut flora don't do so much with the insoluble, they do more with the soluble. Okay. So when we start to look at fiber sources, it's a really good idea to get our fiber from a range of foods, so we're getting a little bit of all of those. Leafy greens, salads, they're great in soluble fiber, but they don't have a lot of soluble fiber. And so they increase a little bit of volume in the colon, but they don't weigh as heavy as, say, chia seeds that have been soaked in water. And the urge to have a bowel movement, to some extent, is determined by bulk in the colon. And when the volume gets to a certain level and the heaviness gets to a certain level is when that starts to trigger the need to go. So again, even a healthy diet, it can be relatively low in fiber. Okay, so I do have, for anybody that wants the PDF of this presentation with the fiber counter in it, I have my email address on the last slide. You can just email me directly and I can send you that. But it's really worthwhile to do a tally. Look on all of your food labels, your bread labels, your pasta labels. Choose the highest fiber options that you can. And if you're having a salad, leafy greens are fantastic, but put it with other vegetables as well, cabbage or peppers, cucumbers to some extent, a little bit of fiber, not necessarily a lot though. Adding things like pumpkin seeds onto there as well. Adding chia seeds into your smoothies or some flax seeds into smoothies. Lots of options. Always keep your skin on your fruits. That's where the bulk of the fiber is. And that will provide a decent amount of fiber too. Yeah, no banana with the skin. No. Your beans and your legumes are some of the highest sources of fiber, both soluble and insoluble. And a lot of people will notice that, okay, well, if I eat too many beans, I really get bloated. They don't sit very well. And so some of that, yes, you may need to try different types of beans. Maybe some will sit better than others, or maybe you're not going to be a bean person. Let's face it, some people are not bean people. But the other thing too is that our gut flora will adapt to our diet as well. And so that's why I say if you're adding fiber, don't just go all of a sudden from 13 grams to 35 grams overnight, but start with maybe, a few chickpeas sprinkled on your salad. And then maybe work to a full bean salad over the span of a couple of months. And your gut flora will grow to be able to accommodate. You're going to select them for the flora that digest that type of fiber. If you're not eating beans, you're not going to have the flora that's going to digest. Okay. All right, so hydration again, we produce 1 liter of saliva every day, 3 liters of other digested juices, including a ½ liter of bile. So hydration is an important piece there too for digestion. Diarrhea, so gut disruptor 3. So common causes, again, food intolerances, undigested foods sit in the gut, they create an osmotic draw, brings more water into the bowel, which then creates a faster transit time. An imbalance in the gut flora, particularly infection C. difficile is probably the top of the list in creating very difficult chronic diarrhea and a long rehab phase after. Any type of traveler's illness or traveler's diarrhea as well can contribute to diarrhea. Medication side effects, SSRIs, antibiotics. Bile flooding, which is what we talked about after some people have gallbladder surgery. If they have fatty meals, then boom, that bile is just pulsed. It's not pulsed, it's just dumped. And that can create bouts of diarrhea. Gut irritation or inflammation from any cause can also disrupt the production of those digestive enzymes. And again, if the food isn't being digested, the bacteria are going to start to work on that and cause some disruption. Irritable bowel syndrome. So irritable bowel is a checklist of symptoms. If you have a certain number of checks on that checklist and other digestive issues have been ruled out through colonoscopy or scopes, then you're diagnosed generally with irritable bowel syndrome. The formal definition is that for at least 3 months, with the onset of at least 6 months previously of recurrent abdominal pain or discomfort associated with 2 or more of the following. So your symptoms improve with bowel movements, or your onset is associated with a change in the frequency of the bowel movement or associated with a change in the form of the bowel movement. So a lot of it, we've got 4 types of IBS. We've got constipation dominant, diarrhea dominant, and mixed, which is alternating constipation diarrhea. And then we have an untyped, which is so unpredictable, we can't really, which in my experience is often the case with IBS. Okay, theories of IBS cause. So there's different things systematically that we need to rule in and rule out. And with IBS, we can't underestimate the effect of stress on the digestive system. And stress associated with serotonin flooding, which again, increasing water in the colon, leading to sometimes urgency, diarrhea, or gas. Undiagnosed food intolerances, sometimes we do find that IBS, once we figure out what the problem foods are, and we're able to find long-term alternatives to those, and they're able to eat those problem foods maybe less often or in smaller portion size, that those symptoms become a whole lot more livable, that there's much more freedom associated. I know, gosh, I know how disabling sometimes IBS can be, and that people are afraid to go on car rides, or they don't go anywhere without looking for the bathroom first. And they don't know whether it's going to be a good day, bad day, so they don't make any plans. And so that really cuts down on freedom, and any amount of control that we can grab back to be able to understand, okay, if I eat this way today and tomorrow, it's very likely that the day after that I'm going to feel a whole lot better. are going to have a good day. If I'm eating in a restaurant, I'm not going to order foods that have this ingredient because that I've already found out is a trigger. So, we may not entirely clear up the natural, the tendency towards IBS, but our goal is to be able to give people with IBS more freedom to come and go, and well, literally, but to be able to not be able to be tied down to their condition. The imbalance in gut flora, the methane producing type of flora in particular tend to slow the bowels down, so they cause more IBS constipation, and there are other imbalances in the gut flora that would tend to promote more diarrhea. And again, inadequate fiber. So again, when someone is in an IBS flare, fiber sometimes seems like the last thing that the gut needs. So we need to gradually work up to that. But once their flare has subsided, our goal is to be able to get that fiber to a level that seems quite sustainable and promotes the healthy flora, perpetuates the healthy flora. Okay, now we're going to move to heartburn, reflux, and GERD. So heartburn is the most common symptom of GERD. And other symptoms, sometimes regurgitation or repeating, difficulty swallowing, a chronic cough, particularly as you lie down at night. And that's because of the irritation. It just feels the throat, lower part of the throat just feels irritated. So there's that constant like this. Dental erosion as well. Sometimes unknowingly, there's some regurgitation at night. So the acidity is affecting the teeth. Laryngitis, again, because of the esophageal irritation. Hoarseness, asthma sometimes too, and belching can be symptoms. So it's the most common diagnosis of all presenting GI-related complaints, and it accounts for about 4% of all doctors' visits. So it's a big deal. It's very common, men and women, and in our youth as well too. 20 to 40% of people with heartburn are believed to have GERD, but it's only considered, quote, significant if it happens more than twice a week. Yeah. Oh, gastroesophageal reflux disease. Yeah, it's heartburn basically, or reflux that has been diagnosed through a scope where you're noticing changes in the esophagus. So that's the formal diagnosis. Our heartburn is our symptom, yeah. Okay. So the GERD drugs, very highly prescribed, or at least they used to be. They're a little more conservatively prescribed now. So 2 acid blocking PPIs are among the top selling pharmaceuticals. Despite this, a complication of GERD long-term is an increase in esophageal cancer. And so that's often why GERD it's not dismissed as a serious condition. It's beyond just feeling the discomfort of heartburn. It can cause erosions in the esophagus, which increases risk. There's a particular type of esophagitis created by GERD that can lead to cancer. So the esophageal cancer, though, even though the PPIs are still widely prescribed, esophageal cancer is still increasing, 200 to 600%. PPIs carry side effects. The PPIs used to be prescribed more kind of as a long-term measure, be put on PPIs and left on PPIs for decades. That is changing. Now PPIs are often prescribed more short-term as we're looking at least bringing the irritation level down in the esophagus. But PPIs, because they interfere, we realize that we need we need acid to be able to absorb calcium and to be able to absorb B12. So taking long-term acid blockers can affect osteoporosis risk, fracture risk, and can increase chance of vitamin B12 deficiency. So factors contributing to GERD. So hiatal hernia can increase your chances of GERD. It produces a separation in that lower esophageal sphincter, that little valve that protects the stomach contents from refluxing up. And so it can create a little bit of a weakness there so that it doesn't clamp as tightly. Pregnancy, again, too, lots of abdominal distension that's happening there and changes in the architecture. Gastric distension. So a lot of upper GI distension when you just feel like full of gas up there, burping and belching, and just feel like you're so full so quickly after you eat. That can also and overeating too, that can also contribute to some extent. Some medications have GERD as a side effect. So some calcium channel blockers for high blood pressure, iron pills, NSAIDs, aspirin, Advil, naproxen, sedatives, sometimes bisphosphonates, which are the osteoporosis medications into themselves sometimes can create some GERD. And then beta blockers, again, used to treat high blood pressure. So if you're experiencing GERD, look at the timeline to see, did it worsen or did it start at a point when you were starting on some of these medications? And there may be other options to talk to your prescribing physician that maybe don't have those level of side effects. Food intolerances can also contribute to some extent. And we find this too, because if we're not digesting those foods, they're being worked on by some of the flora, they're being incompletely digested, so they can create a lot of gastric distension as well. Weight gain shifts as well too. The architecture puts more upward pressure on that sphincter. And so the studies have shown just even 2 pounds of weight loss can actually improve GERD and reflux symptoms too, particularly if that weight loss is from the abdominal area. So if you started to notice as you were gaining weight that the reflux is getting worse, and sometimes it's just purely an architecture related factor. Eating habits, again, eating too fast slows everything down, including the stomach emptying. Low stomach acid, as we age, we produce less stomach acid. We need a certain amount of acid in the stomach to move things along. H. pylori is bacteria that lives in the stomach associated with inflammation and chronic stomach irritation and gastritis. So with diet and GERD, typical gastric diet limits caffeine and alcohol because they do relax that little valve, that sphincter. And so with caffeine and alcohol, that can create more of a laxity, and so can create a little more reflux. Combined with a low carbohydrate diet in the study, actually 68% of people improved. And we do find that clinically that if people are eating a very carbohydrate heavy diet, particularly white carbohydrates, whether that's white pastas, white breads, a lot of wheat-based products, that for some people that is creating a lot of gastric distension, and that too then will create more of an upward trend. GERD in the diaphragm, we talked a little about how the diaphragm moves with every breath. When we are shallow breathing, that diaphragm isn't moving. When we're deep breathing from the belly, like we should be, it's like a micro massage. We're massaging our internal organs that way, and that also helps the passage of food through into the stomach as well. So, action plan here. So kind of summarizing everything that we spoke about. So from a dietary point of view, food intolerances sometimes can impact. We can determine that through elimination and challenge, or we can do a test. The best option is usually to do a combination of both so that we don't miss things. Water intake, important hydration wise. Herbal teas count as well. Anything, not necessarily caffeinated teas and coffee, but ginger tea, peppermint tea, fennel tea. Those peppermint tea sometimes very soothing. Bitter and sour foods, lemon, for example, bitter greens, endive, radicchio, kale, those stimulate bile flow. They help to thin the bile. So a little bit of lemon with your water sometimes helps that way too. Fiber, again, we're looking at in and around 30 grams. That seems exact, but I tell you that a person's normal level of fiber isn't always sitting at 30 grams. For some people, it may be 20 grams, 25 grams, 20. We don't need to be so exact on it, except to say that when you start to look at your foods, give yourself an honest estimation about how much fiber you are getting, and trying to increase that gradually and seeing if that does improve symptoms. 1 or 2 cups of coffee per day, particularly black coffee. And we say this because coffee is a bitter, but once we start putting milk and cream and sugar and syrups in it, it's not a bitter, it's not a medicine. But black coffee itself is a herbal medicine. It is a bitter. And again, that bitter improves the flow of bile. We know too that coffee sometimes acts as a little bit of a digestive stimulant, gets things moving as well. So if you like coffee, particularly black coffee, if you don't like black coffee, then use the bare minimum amount of stuff in the coffee that you can, so you can still maintain some of that bitterness. Weight loss, again, particularly abdominal weight gain, can contribute to some of these symptoms. And then deep breathing as well too, just to help to keep all the architecture where it should be there and to create that micro-massaging environment. Eating habits, we want to eat and chew, and sitting down to eat can't be underestimated, as opposed to standing and eating or eating on the run. Supplements, so sometimes we'll use magnesium, particularly if there are some spasms in the gallbladder duct, sometimes to help with regularity as well. Digestive enzymes have a real following out there, where some people will use digestive enzymes with every meal for years on end. And my interpretation is that if we need to figure out what you're not digesting that well, and let's maybe find some alternatives to those foods so that you don't have to take a pill every day to medicate your indigestion. And so temporarily, at least when a person's digestive system is in awry, sometimes digestive enzymes are really helpful because it gets people out of that acute phase. But in the long run, we don't want you to have to take a pill with every single meal. It's just, it takes the fun out of it. Vitamin C sometimes as well too, probiotics we had mentioned. Supplement iron, but only if the iron levels are low, and again, only then in a well-absorbed form. I find sometimes iron creates more problems than it's worth, and so we really want to make sure if you are taking it, that you do really need it. But by the same token, it's a very common deficiency, particularly in health-conscious people. And lots of other supplements we consider for GERD and for IBS as well too, but there's just, we'd be here for 2 more hours. Exercise again too, particularly it encourages deeper breathing, it encourages deeper breath, and monitoring your prescription medications and seeing if any of your symptoms started or the timeline fits with any of these digestive, whether diarrhea, constipation, GERD, reflux, if they correlate, and discussing maybe options with your prescribing physician. Monitoring your stress levels to see whether that impacts, and doing a little bit of a journal that way, and good gut days, bad gut days. Some people do food journals just to kind of see if they can notice any correlation. Sometimes it's helpful, sometimes it's confusing. Like we mentioned, food intolerances aren't always cut and dry. Eat the food, react, eat it, react. But it's a good start to understand maybe some triggers there. And then considerations for testing, so the food intolerance testing, and sometimes we do a comprehensive digestive stool analysis, and that's really where we look at what flora are in your digestive system. So the good stuff, the bad stuff, how much yeast is in there. And if there are problem flora, then it cross-reacts your strain of problem flora with other kill agents, whether it be pharmaceutical or things like oil of oregano and acrylic acid, and so that it gives us an idea of what your particular strain of bad flora is sensitive to, so we can hit it with something that it's going to be more vulnerable to. So there's my email address. So if anyone wants the PDF version and the emailed version, I'm happy to do that. We made it, 11 o'clock.
So much information. Oh my goodness.
Okay, all right. Well, and thank you everybody at home for attending as well. And thank you so much, Barb, for allowing us to do this here in the studio. It's a beautiful fall day. And and thank you ladies for joining us. Great. And I'll take any questions if anybody has questions. We can.
Questions, Jody? No, thank you, Sarah. That was really good. You answered all my questions.
Yeah, no, that was really,
Okay, great.
yeah.
Okay,
yeah,
good. Thank you.
Yeah.
Thank you. Good.
Yeah.
Yeah.
This is,
And my husband's.
just realized I know. It's like, well, we gotta.
Yeah, our new person's here.
Okay.
And then.
All right. So we'll sign off.
She wants this room.
Oh.